don't normally use unless you have to, okay? Now, the first one there is APRV, airway pressure release ventilation. It is a mode of ventilation that provides 2 levels of CPAP and allows spontaneous breathing at both levels. So we did that in the lab the other day. What it is you set your high pressure, you set your low pressure. So you call it CPAP, okay, because the patient can breathe spontaneously on both levels of pressures, okay? High pressure is set from 15 to 30, okay? Yes, 15 to 30. And then a way of knowing whether the pressure level that you chose will be normal is for you to do a blood gas, okay? At least 1 hour after you place your patient, if you have them on pressure 15, if their CO2 is still high, then you increase it a little bit, okay? So either that or the beginning pressure can be your plateau pressure from your volume control mode. Okay, now let's say that my patient is on SIMVVC or ACVC. Now I want to switch them to APRV. I can do my inspiratory pause, get my plateau pressure, and then that will be the beginning pressure for my APRV, okay? Either you do that or you just, start the pressure of 15 to 30.
That would be like your T high.
Huh?
That would be like your T high.
That would be your P high.
Your
Right.
T high.
Yeah, P high, yeah. Okay, so low pressure is the P low, okay, which basically is your PEEP and expiratory pressure from 0 to 15, okay? That's what you're gonna choose. Patient breathes on a high level of pressure and is occasionally released to the low pressure. So that's why we call it airway pressure release ventilation. So it kind of goes like this. So you have your, let's say that my P high, I have my P high at 30, I have my P low at 5, okay, which is 30 and 5. And then your T high is how long the patient is going to stay at the high pressure. As once they get here, how long, this is time over here. How long will they stay at the high pressure? Your T low is how long are they going to stay at the low pressure? Okay, so now at the beginning of inspiration, the patient is getting to the high pressure, okay, which is 30, and then we stay there for, let's say if I have like 4 seconds here, and then 1 second here. So it will stay for 4 seconds here, and there, and then at the end of the 4 seconds, the patient is released. Okay, this is where it's going to start because I have a PEEP of 5. The patient is released to the lower pressure. And then they will stay there for T low, which is 1 second in this case, right here. And then they're taken back up to P high, stay there for 4 seconds. They are released to the lower pressure, just like that. Okay? Now, one thing with this is that while the patient is up here, they can breathe spontaneously. Okay, so you can set pressure support with this mode. And that will be when the patient breathes spontaneously. So if you're looking at the graph, you will see a little addition of the low pressure like that. That will be an instance where the patient has taken a spontaneous breath while they are up here. Or they can do it here too. So they can breathe spontaneously at the high or the low level. That's what we call a CPAP. Okay? So that's what it looks like. Ventilation occurs when pressure is released from high to low. That's when the patient dumps their own CO2. Once the patient is released down here, it's like they're exhaling. Okay? They dump the CO2. Okay? So in essence, if your T low is very short, the patient can do air trapping. Okay? You want to make sure you set enough T low. But that's the expiratory time, basically. Okay? Remember, it is an inverse ratio ventilation. The I time is usually way longer than the E time. The E time is shorter, okay, than the I time. Triggering and cycling. Both levels of pressure are time triggered because we do set respiratory rates directly or indirectly depending on the ventilator that you're using. Like on the solo I, you don't really have to set, you can't set your rate directly. Okay? your rate is determined by the level of your T high and your T low. As you adjust those two, your respiratory rate will change. Okay? But on the 980, you can directly set your respiratory rate. So it depends on the ventilator that you're working with. Okay? So, but now, so both of them will be time triggered and time cycled. Okay, when the patient is not breathing spontaneously. Spontaneous breaths are flow cycled. Any kind of spontaneous breath, CPAP, pressure support, they will be flow cycled. Okay?
You can't do pressure cycle in this mode?
Excuse me?
Wait, what?
Pressure support? Yeah, pressure support
Never
is.
mind. No, I was thinking triggered, not cycled, but
Oh, it's patient
Yeah.
triggered, yeah.
yeah, no.
Yeah. Yeah, okay. All right. So, yeah, again, you set pressure support so that when the patient does take a spontaneous breath, the pressure support level will help decrease the airway resistance imposed by the artificial airway. Okay, that's how pressure support does. It widens the diameter of the ET tube so that the patient is able to suck out more flow from the ventilator. That's all it does. Okay, so that means then that the higher the level of pressure support that you set, the lower the airway resistance, the more that the volume the patient is going to get because they're going to be able to suck out more flow from the ventilator. If you set pressure support and the patient is not breathing spontaneously, then it's not being used. It's only used for spontaneous breathing. Any patient that doesn't have any spontaneous breathing effort is not a candidate for pressure support because it just sits there. Okay?
So you said spontaneously breathing is,
Huh?
did you say it's
Any patient that is not breathing spontaneously,
full cycle thing?
okay, is not a candidate for pressure support. Just like BiPAP is basically pressure support. If somebody doesn't have spontaneous breathing effort, you don't put them on BiPAP, you put them on the ventilator. Okay?
So pressure support, is that like, because you have the P high and the P low, is pressure support just a completely different, separate thing from those?
Correct, correct. Yeah, it's just, when they breathe, like say the patient is taking the T high and they're up here, and then they have the need to breathe on their own. So that's when they're gonna use that pressure support. Okay? But if they're not breathing spontaneously, then it's flat like this.
Okay, so it's pressure support on top of the
On top,
P high?
yeah.
Okay,
Yes, on
got
top,
it.
yeah, on top
Got
of that. That's the way it's gonna look too on the graph. You see a little indentation top or down there. Okay? Okay, so now there is a ventilator called the Draga Evita. Okay, that's the ventilator that they use at the VA hospital. A long time ago, we used to go over there for clinical, but we stopped going there because the clinical instructor there resigned, and it's been very difficult to get somebody there to teach. But The Draga Evita is the first ventilator to come up with that mode called the APRV. So on that ventilator it's called the APRV. And then after the Draga Evita brought out that mode, other companies started making similar modes, APRV, but called none of them on their ventilator. Okay? So like on the 980, that APRV is called bi-level. So if you're ventilating your patient with the Puritan Bennett ventilator like the 840 or the 980, and the doctor wants you to do APRV, you'll be looking for a mode that is called a bi-level. If you're using the Sovereign, okay, and you want to go to the APRV mode, you'll be looking for a mode called the bi-vent. Okay? And again, APRV is equivalent to pressure control inverse ratio ventilation. Like if you're on a pressure control mode, regular pressure control mode, and you inverse your ratio where your I time is going to be longer than your E time, basically you're doing APRV. That's just another name for it. That's what it is. It's an inverse ratio ventilation pressure control mode. And one more thing about this pressure control inverse ratio ventilation, you remember how we talked about if you were ventilating your patient on a volume control mode like SIMVVC or ACPC, now their PIP is going over 50 or plateau pressure above 30, and you want to switch into pressure control mode. If they give you APRV mode, pressure control inverse ratio ventilation, you pick it. The same thing. It's pressure control. It's just that you have an inverse ratio. Okay? Because sometimes they just give, I've seen where they just, give you that and not just say pressure control. But it is pressure control mode. Okay? Now, there is a ventilator called the Hamilton Galileo. Okay, they don't use it in this area of the country, but Hamilton Galileo. Okay, though, on that ventilator, they call the APRV CPAP with release. The same thing, CPAP with release. And then there's a ventilator in which they call that variable positive airway pressure. It varies. It goes to this pressure and then it comes down to this pressure and then it goes up. So variable positive airway pressure. The same thing. Any questions about this? Advantages and disadvantages of APRV. Well, the first advantage is that you would have lower PIP. Okay. Now, lower PIP means fewer risks for barotrauma. Okay, you're likely not to develop a barotrauma. Better oxygenation. And the reason for that is it is very good for lung recruitment. Okay, now, like I said lung recruitment just means that you are popping open more alveoli. Okay? Studies done way back, like a few years ago, showed that what actually increases oxygenation is how many alveoli that you have open, not necessarily to the extent in which you distend them. Okay? So the more alveoli that you have open, the higher your oxygenation will be. So this mode is very good in recruiting lung units. Better gas exchange without hemodynamic complications when treating acute lung injury and ARDS. And that is true. There's better gas exchange. Hemodynamic values like the blood pressures. Okay. Hemodynamic is just about blood pressures. So your blood pressures will not be affected much when you're treating acute lung injury or ARDS. I mean, these two types of diseases here would have extremely low lung compliance, okay, which will necessitate you to use high pressure. Okay. Well, if you're doing it with the APRV, then that means that your hemodynamic parameters will not be out of whack. Right? Is that how you say whack? Out of whack?
You got it.
See, I'm gradually becoming an American here. It reduces mean airway pressure because the patient can breathe spontaneously. Okay? Patient is able to breathe spontaneously on this method. Just like if you compare SIMV VC and ACPC, okay, SIMV reduces mean airway pressure because not all the breaths are positive breaths. Whereas if you go to AC mode, all the breaths, whether the patient is triggering or the ventilator is triggering, they are receiving the same type of the same amount of pressure. Okay. Overdistension and reduction in cardiac output are minimal, and again, the patient is breathing spontaneously, and then that doesn't appear to decrease their cardiac output. Spontaneous breathing is good for cardiac output. Okay. If your patient is on ACVC and they have very low blood pressure, if you switch them to SIMV-VC, your blood pressure will go up. Okay, because not all the breaths will be positive breaths. Disadvantages. Volume delivery depends on patient's lung compliance and resistance. It is pressure control mode. It is pressure control mode. So remember, on any pressure ventilation, when compliance goes down or resistance goes up, tidal volume drops, and vice versa. So the same thing with the APRB mode. Volume delivery depends on patient effort, and that is true. That's another thing that affects the magnitude of tidal volume that the patient can receive. Okay, you have to be able to suck in to generate more flow. CO2 buildup may result in COPD patient owing to increased airway resistance. That is true. We want to make sure that we set enough E time. Okay. We said, although the I time is going to be longer than the E time, but we want to be sure that the E time is at least enough for them to dump their CO2. It requires adequate staff training, which is true. Usually when you graduate from here, they don't put you in the ICU working with the APRB mode. It's a little confusing. They let you, work with somebody for a while so that you can understand the mode. Okay? And not all ventilators can do APRB. That's another thing too. Okay? We have some ventilators out there that don't come with the APRB mode. Okay? Now, settings here, P high. Okay? Like I said, now you may use your plateau filter from the volume control mode, or maybe otherwise you just say 15 to 30, and then you have to do a trial and error. Well, is this pressure enough? Well, how am I going to know that? Let me get a blood gas. Well, it's not enough. Let me turn it up to 18. You check another blood gas. But now, if you use your plateau pressure is the amount of pressure that is used to ventilate the lungs. Okay, expand the lungs. So, if you use it, about 90% of the time, your blood gases will come out right the first time. Okay. Now, the PI is the pressure that gets the tidal volume. Okay, it's like your PIP on the pressure control mode. PI is like your PIP on the pressure control mode. So anytime you want to increase your tidal volume, your exhale tidal volume, you increase your PI. Okay? If you have high CO2 and you're in this mode, you want to blow it up, one of the things that you can do is to increase your PI to get more tidal volume. Okay? P-low. P-low is like your P. It's basically like for oxygenation, really. Okay? And then you may begin anywhere between 0 to 5. There are some disease processes that we don't set PEEP to begin with, okay? We always want to set PEEP at least 5 minimum, but if the patient is having some disease like bullous emphysema, you gotta be very careful, because that can cause pneumothorax, okay? But 0 to 5, okay, I will always say it to something anyway, unless I know that there's contraindication that patient has. T high, studies have shown that anytime you set a T high that is up to 4 seconds or a little more, then you will have enough mean airway pressure. Okay? Mean airway pressure. Mean airway pressure usually increases your oxygenation. Okay? And then here's the T low, 0.5 second to 1 second. Very small time there. Okay, so, like I said now, depending on the ventilator that you're working with, you may be able to set your rate directly, or you may not be able to set it directly. So, let's take the Servo I, for instance. On the Servo I, you can't control your respiratory rate, okay? You set your respiratory rate by adjusting your T high and your T low. So here's an example here. The T high there is 4.5 seconds. That's my I time, the high pressure, okay? Total cycle time, it was I time plus E time. So my T high is 4.5 seconds. That's my inspiratory time. My expiratory time, which would be my T low, will be 0.5. So if I add those two together, I will have 5 seconds, right? And then if I divide 60 seconds in 1 minute by the 5, my respiratory rate will be 12. So if I'm looking at that screen, I will see a respiratory rate of 12. Okay, based on what I said here. Okay, so now, what you're gonna find out is, as these two numbers here, you add two of them up and they increase. As the sum increase, the respiratory rate decreases. Okay, so now let's say that now I make this one here 5, and this is 0.5, or maybe 1. So I have a total of 6 now. Then my respiratory rate here becomes 10. So basically, that's the way you set your respiratory rate. You have to adjust your T high or your T low, and then the ventilator will calculate the respiratory rate. But you can't set it directly on the servo. On the 980, you can do that. Okay? Any questions about that?
Is this a realistic example here?
Huh?
Is this a realistic example? Because the I time would be
Yeah, I time will be now, I to E ratio, yeah, I time is 0.5,
yeah,
4.5, and E time is 0.5. So if you work that out, you're gonna have like 4.5 to 0.5. So 0.5 divided by 0.5, we're doing the I/E ratio. So this will be 1 to, what would that be? 9. So we have inverse ratio of 9 to 1. It goes up that high. Okay? Because what you're trying to do is to increase the mean airway pressure. Okay? Patients go like that. So they're holding the pressure there. That's artificial PEEP, okay, which improves oxygenation as well as ventilation. Patients get very sick to be on this mode. Okay? Are very sick. ARDS. Okay? Does that answer your question, Ray? Okay. All right. Another thing that I want to tell you about the I/E ratio, calculating the I/E ratio, you always divide by whichever one that is the smallest, has the smallest value. If your E time is smaller, you divide both of them by your E time. If your I time is smaller, you divide both of them by your I time. Because on the exam, they may give you a scenario where you have to calculate inverse ratio. And if you're trying to divide by your I time all the time, it will never come out right. Okay? All right. Tidal volume and flow delivery depend on the same factors as in conventional pressure control, which is true. In the traditional pressure control, increase in pressure increases starter volume. The same thing here. Okay? Increase in compliance or decrease in compliance, decrease in resistance increases starter volume. Okay? Increase eye time, okay? Increases starter volume. Okay? Increase patient effort, increases starter volume. Those four things are factors that affect the magnitude of excess starter volume on pressure control. It will be the same thing here, because it is a pressure controlled mode. Okay? Okay, so now how about if you're having respiratory alkalosis, okay, on this mode? So you want to decrease your respiratory rate. So look at it. If I have this scenario here, what I'm going to do to decrease my respiratory rate is either to increase my T high or my T low. See, it's kind of confusing. You know, you increase your T high or T low, which would then increase the sum, the total cycle time, such that when you divide it out, you have lower respiratory rates. Okay?
Does it matter which one we increase?
No, you just have to make sure that they have enough T-low so that they're not doing air trapping. But mainly T-high, because it has a bigger value than the T-low. Okay? Respiratory acidosis. Okay? Well, you can increase your P-high. That gives you volume. That's one way that we treat respiratory alkalosis. That increases your exhaled starter volume plus more CO2. Or you can shorten your T-high. Okay, so if you shorten this, make it 4.5 now, okay, this here will increase your respiratory rate will increase. And then you blow up more CO2. So that's why it's a little confusing. Okay? And then if you want to increase oxygenation, you can either do that by increasing your P-high, because you know the idea there is that the more you ventilate the patient, the more you oxygenate the patient. Okay? You have to ventilate them well to oxygenate them. Well, if you don't want to do that, then you use your FiO2. Okay, assuming that they already have normal CO2, and I know that increasing the pH will cause CO2 to go below normal, then I can increase my FiO2. But if I have high CO2 with poor oxygenation, then I can increase my pH.
Couldn't increasing P low also do that though? Couldn't increasing P low also do that though? Because isn't that like PEEP?
Yeah, increasing the P low is mainly for oxygenation. Yeah, you can do that. You know, yeah, basically you can do that. Yeah, you can do it, but you don't want to, you know, make the expiratory time, you know, too long. Yeah, but technically you can do that. Okay, but that's what your book says there. Okay, discontinuing APRV. Okay, so when you get ready to wean them, because now remember the reason that you're going to put them on this mode is because they have low lung compliance. Their lungs are very stiff. Okay, so you know, to determine whether they still need this, they're going to have increase in lung compliance. Okay, it's kind of like pressure control. You go from assist control or SIVC to pressure control because they have low lung compliance. When we want to switch them back to volume control, we want to make sure that their compliance, their lung compliance has improved. Okay? So what we're going to do is we're going to decrease P-high, okay? And they can have very low pressure, but are getting high tidal volume. That's a sign that their lung compliance is improving, okay? They're getting huge tidal volume with low pressure, okay? So that's why we're gonna start decreasing the P high a little bit, and then we'll monitor the exhaled tidal volume. If the tidal volume is still within the normal range, then their compliance would have improved, okay? Then increase T high in increments of 0.5 to 2, so meaning that you are decreasing their respiratory rate, okay? If you decrease their respiratory rate, they ought to be breathing more on their own, okay? And then eventually, when you have gone very low on both of them, you just switch them to CPAP. CPAP, continuous positive airway pressure. You set the level of pressure, which is P, basically, and then the patient breathes on it, okay? If they're still doing okay spontaneously with good tidal volume, normal vital signs and stuff like that, then you can extubate them, okay? Any questions about APRV? Okay, so this one here is pressure control, inverse ratio ventilation. So it's the traditional pressure control where you have inverse to your ratio. Okay, so that's what we do in the ICU. Initially, when you put them on pressure control mode, it's gonna be 1 to 2, 1 to 3, 1 to 4. And then down the line, their lungs are getting stiffer. Okay, that 1 to 2 normal or physiological ITE ratio is no longer working. So we want to inverse the ratio so that we can create PEEP, intrinsic PEEP, okay, to increase the mean airway pressure. Okay, so basically that's what you're doing, okay? But on the traditional pressure control, you can only do up to 4 to 1. The I time will be 4 times greater than the E time, okay? The ventilator will not allow you, okay, unless you go to APRV mode, the ventilator will not allow you, will not allow the patient to use more than 80% of the total cycle time for inspiration, okay? But if you go to APRV, then it will allow you to do that. So the most you can do is 4 to 1, where your I time will be 4 times greater than your E time, okay? This mode increases mean airway pressure, which is true. You are holding more pressure inside your chest. It would tend to bring down your blood pressure, so we're going to be monitoring the blood pressure as well, okay? Patients may be sedated and paralyzed. Yeah, that is true, because this is not a normal way of breathing. The normal way of breathing is that your I time has to be shorter than your E time. But now, your I time is 4 times greater than your E time. Okay, so you're going, okay, so patients don't tolerate that well. For them to tolerate it, you're gonna have to sedate or even maybe paralyze the patient. Okay? Any questions about that? So that's why APRV will be better than this. Okay? Because it doesn't affect cardiac output as much. So the next unconventional way is the Heliox therapy. If you go to the hospital, you don't see a lot of people on Heliox therapy. We'll give it to them when they need it. It's not a very routine therapy. Okay? Well, Heliox just means that you have a mixture of helium and oxygen. So we call it Heliox therapy. Okay? And helium is a lighter gas than oxygen. Okay, it's lighter than oxygen. So what happens then is that when somebody has obstructed airway, okay, that is threatening hypoxemia, okay, the oxygen cannot flow around the obstruction into the patient's lungs, okay? So what we do is we mix up the helium with oxygen so that the helium can carry the oxygen around the obstruction into the patient's airway so that we can oxygenate the patient, okay? So that's why we do Heliox therapy, okay? It will lower the airway resistance, okay? It lowers the airway resistance, that's another way to do it, to say it. These are instances where you may need heliotherapy for a patient. Post-extubation straddle, okay? Now, it's not severe because if it is severe, we know what to do, right? If it's severe, we're gonna reintubate the patient. That means that swelling is so much now that if you don't do anything, it's gonna close up. But if they have mild or moderate straddle that doesn't wanna go away and they have hypoxemia with it, we can try them on heliotherapy, okay? Asthma, okay, you have a lot of airway obstruction in asthma. We can do heliotherapy if they have hypoxemia with it. If they have tracheobronchitis, we can do that. If they have viral laryngitis, laryngotracheobronchitis, which is croup, that's our name for croup. We can do that. Bronchitis, tumor in the airway, person obstruction, foreign body aspiration, vocal cord paralysis, dyskinesia, which is where the hairy-looking structure on the wall of the trachea is not beating good effectively. COPD. Okay, so these are instances. So we mix up the helium and the oxygen in different proportions. Okay. Now there is 80-20 mixture. Okay. That is the standard mixture. In that mixture, 80% of the mixture is helium, 20% is oxygen. So now on the blood exam, they say, what is normal heliotherapy? That's 80-20. What is standard heliotherapy? That's 80-20, okay? However, we have 70-30. So 70% is helium, 30% is oxygen, okay? Now, the more oxygen that you have in the mixture, the less the effect of the therapy. Okay, because now the whole thing begins to get a little heavier, you know? And then we have 60-40, 60% helium, 40% oxygen. They use that one a lot for the babies. Okay? All right. So the next thing now is that when we deliver the heliox, we are using oxygen flow meter. There is nothing like a helium flow meter. We use oxygen flow meter. Okay? So because the helium is much lighter than oxygen, anytime you set a flow rate on the oxygen flow meter, okay, the flow that is actually going to the patient is more than what you set on the flow meter. Okay, like say if I set 10 liters per minute, that's not what the patient is receiving. The patient is actually getting more than that, okay, because of the lightness of the helium in the mixture. So as a result of that, we have correction factors. Okay, correction factors. Like if I'm doing the 80-20 mixture heliotherapy, okay, whatever I set my flow at, the flow that the patient is receiving is 1.8 liters more. For instance, I have my flow meter set on 10 per minute. What my patient actually is getting, what is going to the patient is 18 liters per minute. That should be 10 times 1.8. Okay? If I'm doing the 70-30, okay, the actual flow going to the patient is 1.6 more than what I said on the flow meter. If you're doing the 60-40, it's 1.4 more flow going to the patient. Any questions about that? So, before I move forward, on the board exam, they may say that a patient is on heliotherapy, 80-20 heliotherapy, with a flow rate of 4 liters per minute on the ventilator. What is the actual flow going to the patient? So you're gonna go like actual flow equals correction factor times liter flow. That's the formula that you have to know. Correction factor times liter flow. So I go like, well, I'm doing the 80-20. So my correction factor will be 1.8. And then I'm on 4 liters per minute. So my actual flow, what is actually going to the patient is this times this, which will be like 2 there, 7.2 maybe.
Mhm.
Yeah, 7.2 liters per minute. Okay, is what is actually going to the patient, although I have it set on full. And then sometimes they may ask you that the other way around. They may say, well, the patient is on Helios therapy and the actual flow going to the patient is 7.2. What is the setting on the flow meter? Okay, so in that case, you're gonna go, well, like actual flow is 7.2. Equals correction factor is 1.8, and then you're looking for your liter flow. You set it the other way, and then if you divide 7.2 by 1.8, you are back to that 4 liters per minute. So they can ask it either way. Okay, it will be on the board exam because as a respiratory therapist, you need to know how to do that. You may be working the night shift by yourself, and the patient needs Helios therapy in the ER. You have to understand it. So that's why they always put it on the test. Okay? All right. Now, we use the non-rebreather mask to deliver that. The non-rebreather mask to deliver that. So now, then the same rule about the non-rebreather device will apply. Okay, we always start with a flow rate of 10 to 15. Okay, so if you started at 10 liters per minute, and then anytime the patient breathes, the bag collapses by more than half. You increase the flow. We do the same thing with oxygen. Okay. So that's how you know whether the flow rate is adequate. By how much the bag is collapsing during inspiration. If it's collapsing all the way down by more than half, you increase the flow. Okay, something. We can hook it up to the ventilator, okay? So that the patient can get Helios. If a patient is receiving a breathing treatment, okay, they have a bureau order to receive every 4 hours or whatever, and they are on Helios therapy, you're gonna have to power that nebulizer with Helios, not oxygen. Because if you do it only with oxygen, they're gonna have hypoxemia. But the oxygen itself cannot go in. So you have to power it with the nebulizer, with the Helios. All right, so another unconventional way is what they call the independent lung ventilation. Sometimes you may want to ventilate the right lung differently from the left lung. I mean, if the left lung is very sick or bad, okay, you may not be able to put a whole lot of Tadovime in it. For instance, if one lobe is removed from the left, you will only have one. Well, if I have 500 going inside the right lung, I can have 500 going inside the left lung as well, okay? Or maybe I have severe infection, okay, on the right side, but the left side is good. Well, I don't want that infection to get over here. So sometimes you may need to ventilate both lungs independently, okay? So that's what we call independent lung ventilation. And another thing that you want to know is that during mechanical ventilation, gas flow takes the least pathway of airway resistance. Gas flow into the lungs takes the least pathway of airway resistance. So basically what that means is that, let's say that my problem is on the right side, okay? Put the ET tube in, when the gas comes, because of the high resistance on the bad lung, it will avoid it and go into the good lung. Okay? So what happens most of the time is that in an attempt to fix the bad lungs, you destroy the good lung. So that's what we see with mechanical ventilation, okay? So that's why this is very important, okay? It's just like, let's say now that, what would be a good example now? Let's say now that you are coming to Pima in the morning, okay? And then there, you can go two ways, either you follow this way or you go that way. There is a car wreck over here on this road here, where you are going to avoid it. Even if it's closer, you avoid it and go that way. The same thing with mechanical ventilation, right? All right, so now, independent lung ventilation is also called unilateral lung ventilation. So when they say unilateral lung ventilation, they're talking about independent lung ventilation. There is a special type of ET tube that we use to do that. Because a patient will have two ventilators. You look at two different ventilators on the same patient, okay? So what we call that ET tube is Collins tube right here. Or you call it the double lumen endotracheal tube. Double lumen endotracheal tube or Collins tube. If they want to be funny on the exam, they call it the Collins tube. Okay, so you have to remember that. So this is the Collins tube here. You can see it's actually one tube, but on the inside of it, you have two channels on the inside of it. So once you shove it down, okay, the end of it, if it goes to the right, that's fine. If it goes to the left, that's fine. Okay, but what you're gonna see is that if it goes to the left side, it has one cuff on the end here, and then another cuff here. This is called the pharyngeal cuff, okay? And this is the endobronchial cuff. So once it goes in here, you seal that cuff, okay? And then you blow out this cuff as well. So now you have two things sticking out here. So you hook up a ventilator here, you hook up a ventilator here, okay? Now, this ventilator here will go to this left lung over here. And this one here goes here. There's little holes here. Okay, little holes about right here. Now this one here will come out and go into the, actually this is the right lung. It goes into the right lung, okay? So that's the way it works. Okay, two ventilators, ventilating one patient.
So if you only want to really ventilate one lung, how would you set the vent on the other lung? Would it just be like minimal settings?
Yeah, you can do it synchronously or asynchronously. Okay, meaning that both of them can cycle at the same time. If you want both of them to cycle at the same time, then you're setting the same rates. Okay? Yeah, because if you set the same rate, you have the same total cycle time. So both of them will cycle. This one here ventilates this lung, this one here ventilates that lung. Okay? With different tidal volume, of course. Okay? So please remember Collins tube. You use the Collins tube for independent lung ventilation. Okay? Now, these are instances where you want to use independent lung ventilation. Thoracic organ transplants. Okay? Lung volume reduction surgery, meaning that they remove the lobe or two lobes, okay, on one side of the lungs. Okay, so the tidal volume cannot be the same. Pneumonectomy is where they remove the whole pleura. They remove the entire right lung or the entire left lung. Okay, pneumonectomy. Pulmonary hemorrhage, they are bleeding like crazy inside one lung. Okay. Isolation of infected secretions. You have infection on one side, but you don't have it on the other side. And video-assisted thoracoscopy, okay? Examination of the chest, that's what that is. They use a light, fiber optic light, and examine your chest, okay? Requirements, you require 2 ventilators for 1 patient. The ventilators can be synchronous or asynchronous, meaning that whether you're gonna set the same rate or different rates, okay? Okay, so the next one is high
Doctor,
frequency. Yeah.
Sorry, one more question.
Uh-huh.
This is confusing me so much. How do you suction a patient with that kind of ET tube?
Huh?
You, Kiara, I was just the same thing.
It will be,
How do you suction them?
or how do you suction them? Okay, now, there is, are you familiar with, what do they call it, wait a minute, that suction catheter that is designed to go to the left side.
The
Oh,
quad,
like cod
Huh?
tip or whatever?
quad tip,
What do you call it?
the quad, the quad.
Yeah, that's it, yeah. Yeah,
Okay.
it's something like, but it's another name that I remember with. Angle something, angle tipped. Angle tipped, that's it, that's another name for it. So that one, if you want to suction the left lung, once you put it down, it will tend to go to the left side, okay?
Just by its shape.
Mm-hmm. That's the way you're gonna suction them, okay? All right.
That makes sense, thank you.
Angle tipped, yeah. All right, now the next one is high frequency ventilation, okay? Now, high frequency just means that you are using high respiratory rates and very low tidal volume, okay? High respiratory rate and very, very small tidal volume, okay? Now look at the rate there, we measure it in hertz. So meaning that if you set like what you would call 60, the respiratory rate is 60, okay? What you're gonna call that is 1 hertz, like that. So 60 cycles equals 1 hertz. Now if you multiply 3 by 60, that's 180, right? So instead of saying that the patient has a respiratory rate of 180, you just say that their respiratory rate is 3 hertz, okay? And then you multiply 15 by 60, you see the kind of number you get, okay? Very high number, so it's going, vibrating the patient's chest, okay? Studies have shown that high frequency ventilation is good. It's as good as pressure control in preventing acute lung injury. That is true, because you're using very low tidal volume, okay? The lung damage there will not be much. An alternative method of ventilation in patients with acute lung injury or ALDS. Okay, when you have ALDS, your lung compliance is very low, you have stiff lungs. So if we try to put in huge tidal volumes, that can cause your PIP to go higher. So we try to avoid that. It is an alternative method of improving oxygenation while reducing the risk of ventilator-induced lung injury. Does anyone remember the difference between ventilator-induced lung injury, VILI, and LA?
Acute lung injury.
Okay, so,
Is it like out versus inside of the hospital?
huh?
Is it like outside of versus inside of the hospital?
Okay, so the VILI is like microscopic, okay, damage to the lungs caused by mechanical ventilation. This is macro, that's bigger, you can see it. So this one here has been proven. This one here has not, okay? Because now, think about it, how are you going to say, this is like a back and other things, subcutaneous barotrauma, all of that. Now this one here is damage to the lung unit, like alexis and things like that. Well, they did this with animals, okay? This is in human, okay? So for instance, you can tell somebody, well, please can I put 2.5 liters of volume in you and see what happens? You know what's gonna happen, right? You're gonna boom, like that. Okay, so that's animal study, and this is a human, okay? All right. Low risk of overdistension, and that is true because of low tidal volume. Good in ventilating patients with bronchopleural fistula, yeah. like now, bronchopleural fistula is like tiny hole between your lungs and the pleural space. So as you ventilate your patient, the volume leaks into the pleural space, okay? If you have huge volume going inside the pleural space, pressure there builds up very quickly, and then you start compressing the lungs. But this one here is going like that, with tiny volumes, okay?
So is this an oscillator?
Huh? Yeah, it's an oscillator, yeah, yeah, that's what it is, oscillator, yeah. They have four, let me see if I can remember all of them. They have four different types of high frequency ventilation. Anytime you exceed a respiratory rate of 60, you're actually doing high frequency ventilation. They have high frequency positive pressure ventilation, okay? Now, this one here, high frequency ventilation. So this one here means that you're using the regular ventilator that we have in there, and you're exceeding a respiratory rate of 60. But those ones can go up to a rate of 150 if you want to. That's the max. And so it is a type of high frequency ventilation. And then they have high frequency flow interruption ventilation. That's a type. And then they have high frequency oscillatory ventilation. And there's one more.
The jet,
Huh?
the jet,
Say it again?
is there one with a jet oscillator or something?
Yeah, oscillator. Oh, yeah, that's it. They have high frequency oscillatory. No, is it something? Yes.
Jet.
I don't remember, but it's four of them. And you know what distinguishes one from another is the amount of rate that they can provide. The oscillation is one that provides the most rate, I believe. Okay? Okay, so now, you don't really have to know all of this unless you want to work in the NICU, And if you're going to work in the NICU, they're going to train you anyway, Because usually you don't see that in clinical, like if you're doing your NICU now, if you go, they may not have it, okay? UNM would be the best place to actually see one because they have more babies than anybody else. Okay, but the only thing you need to know about high frequency ventilation is, these 3 settings here on the exam, as far as the exam is concerned. On any of those types of ventilators, there is a knob or control knob that says mean airway pressure. Okay? There's one that says amplitude. There's one that says frequency. Okay? So mean airway pressure increases oxygenation. Okay? So they said a baby is on high frequency ventilation mode, their PaO2 is lower than 50. What are you going to do about it? You're going to increase the mean airway pressure, and you're done. Well, they have respiratory acidosis, and they are in high frequency ventilation. What are you going to do about it? You're going to increase the amplitude. Increasing the amplitude is like increasing your PIP. Okay, that gives you a little bit more tidal volume to blow up more CO2. So with respiratory acidosis, you increase the amplitude. With respiratory alkalosis, you decrease the amplitude. Okay? With low PaO2, you increase the mean airway pressure. With high PaO2, you decrease the mean airway pressure. And then frequency is there for you to use if you don't want to use the amplitude for some reason. If you have respiratory alkalosis, acidosis, you increase the number of the hertz, okay? If you have respiratory alkalosis and you don't want to use your amplitude, you decrease the number of hertz. Any questions about that? That's all that you will ever see on the exam about this, that's all. Okay? And then we have, I don't have time. Okay, so, we have pediatric and neonatal ventilation, okay? You have to, know the parameters here. If you're gonna put a patient, a pediatric patient on the ventilator, okay? You are going to still use 6 to 8 meals per kg. Most of the time, they won't give you the height. They will give you the weight. So if the weight is given to you, you use the weight and multiply it by 6 and then multiply it by 8. Okay? Because most of them will be less than 5 feet tall, right? I'm still yet to see a pediatric patient that is more than 5 feet tall. Yeah, so they make you use the weight because it becomes a little complicated trying to work that formula. Okay? Lower tidal volume is required. Usually the tidal volume is about 80 to 200 milliliter. Okay? Their initial respiratory rate, 20 to 30. Remember, for adults, it's 10 to 20. For pediatric patient, it is 20 to 30. The lower the number above 20, the better. Okay? But you can go as high as 30. Otherwise, the ventilation mode is the same. You can do assist control on them, you can do pressure control of them, you can do SIMV on them. Okay, just like we do for adults. What actually ventilates the patient is the parameters that you have inside the mode, not really the mode. Which one has the best kind of volume, which one has the best respiratory, which one has the best FiO2. Don't worry about the mode, okay? And again, remember, tidal volume rules. Okay, you get your tidal volume down first. If you have several options where the tidal volume is the same, then you move to FiO2. FiO2 is second. Which one has the lowest FiO2? Okay? Now, initial FiO2, the same with adult. No history of being on oxygen, 40 to 60. The lower above 40, the better. Okay? They are on oxygen, well, the same FiO2 when they're going on the vents. They are on CPAP, where you give them CPAP, the same amount of CPAP. Okay. They have emergency, you give them 100%. If they have cardiac arrest or respiratory arrest, 100%. Pulmonary edema, 100%. CO poisoning, 100%. Near drowning, 100%. Myocardial infarction, 100%, regardless of the FiO2 that they have been on. The same thing with adults. So we'll go over here for neonates. Neonatal patients are usually ventilated on pressure control mode, period. Pressure control mode. SIMV PC is preferred, okay, because the patient can breathe spontaneously and not have a lot of mean airway pressure, which will affect their blood pressure. Okay? So it's not like you can ventilate them on ACBC mode, but SIMV-BC is preferred. And if you're given both of them, you pick SIMV-BC. That's the best. Okay? Respiratory rates for the baby, 25 to 40. The lower the number above 25, the better. Okay? Pressure. Okay, well, pressure will be 20 to 30. The lower the pressure above 20, the better. Okay? FiO2 requirement is the same for adult and pediatric patient. Okay, same thing. No oxygen, 40 to 60. They have oxygen, the same FiO2, and so on and so forth. Okay. Now PaO2 for a baby is 50 to 70, no more than 80. You gotta remember that. Read the question very carefully. Know the type of patient that you get. Okay? Because now they can give you a baby and give you a PaO2 of 90. unless you read that question very well and know that you're taking care of a baby, you would think that the PaO2 is normal, because normal PaO2 for an adult is 80 to 100. PEEP should not exceed 8. Okay? If the PEEP is to exceed 8 and the baby is premature, you are better off giving them surfactants. Because if you improve their lung compliance, then they would not need more PEEP. Any questions about that? So that's the end of